Hi, good afternoon, and welcome to today's webinar on the pathophysiology of spasticity. My name is Chris Ashton. I'm the coordinator for the newly merged Greater Manchester Neurorehabilitation and Integrated Stroke Delivery Network, and I work in conjunction with Gemma, who's previously facilitated some of your training webinars. I'm also joined today by Lisa Chadwick, our network administrator. So if you've got any technical issues today at any point, please feel free to email Lisa on lisa.chadwick@srft.nhs.uk. Now, during today's webinar, we're going to use the speech bubble icon at the top of Microsoft Teams Live. And here you'll be able to pose any questions to our relevant speaker. And I'll obviously keep an eye on these and make sure that at the end we can pose these to Dr. Morcos. Additionally, we're also going to ask you in the question and answer function to actually pass on your feedback today about the webinar and any content. And we'll ask you to actually put a numerical score in there, please, if you don't mind, at the end of the session, between 1 and 5, 1 being poor and 5 obviously being excellent. And pose any relevant additional feedback you may feel, even if it's constructive, that's fantastic, obviously, because we use the feedback to drive future webinars. So many thanks for doing that. And obviously at this point, I'm now going to pass over to today's fantastic speaker, as we're joined by Dr. Morcos, and he's going to talk to us about the pathophysiology of spasticity. And I thank him for his very valuable time that he's taken out of obviously clinical practice to help deliver this webinar today. So thank you very much, Dr. Morcos, and over to you.
Hello, everyone. Thank you for attending this part of the training on spasticity. My name is Morcos. I'm consultant in rehabilitation medicine, and this session is about pathophysiology of spasticity. I'll try my best to make it simple and short. Basically, to start with, this is a lovely picture of the neuron. The neuron actually doesn't look like it's colorful, however, it's here just to explain the unit of the nervous system. You have the body or the soma with the nucleus. You have the dendrite, where the neuron receive messages, and then you have the long axon where the neuron actually send messages and actually connect or synapse with other neurons or other organs. The axon could be covered with myelin sheath and neurolemma. This is facilitate the conduction, as we'll see in a minute, and also help recovery. This is mainly in the peripheral nervous system rather than central nervous system. So, as we said, there is, generally speaking, a couple of types of nerve fiber or axon, myelinated axon and unmyelinated axon. So basically, as you see from the picture, the action potential of the nerve fiber, which is actually, this is how the nerve conduct impulses, where the resting potential basically have positive charges outside the membrane and negative inside. However, the depolarization, where these two things flip, so the negative charge will be outside and then positive is inside, and then the repolarization when it comes back again. And this is more or less the nerve impulse. The difference between the nerve conduction in the unmyelinated axons, as it says, it shows it in the picture. In the myelinated is actually kind of jump. So that is a pretty fast conduction, in contrast to the unmyelinated will be kind of creep, and basically it is a bit slower conduction. How do we actually move? How do we actually produce the movement? And I'm going to try my best to make it simple here. The actual volition of the movement originate from the pre-central gyrus in the frontal lobe. This is the red bit in the brain here, and which actually the cells here, this is called upper motor neuron cells, send basically the axons downward, and there's plenty of them, so this make a proper big tract called corticospinal tract or pyramidal tract. The tract, most of the fibers of the tract cross to the other side in the brainstem, mainly the medulla. The rest will go in the same direction, but later on it will cross too. The actually tract will end at another cell in the anterior cone of the spinal cord, and other cells actually as well in the brainstem. These cells we call them the lower motor neuron cells. So we have two cells, upper motor neuron and lower motor neuron. The lesion in these cells are quite different, and in here we'll mainly concentrate in the upper motor neuron rather than the lower motor neuron. Well, here is how the nerve actually fiber communicate with the muscle fiber. So this is electron microscope picture of the nerve ending and what we call it the motor end plate. This is the connection between the end of the nerve and the muscle, and this is how the nerve talk to the muscle. Another similar picture. Why did they put it? Because I like it. It's pretty beautiful, basically structure. We'll see it a bit in depth. Here, this is just a drawing which shows this is the actually nerve ending, and this is the motor end plate. This is what we call it synaptic cleft. This is the axon, this is the myelin around the axon, and actually in the nerve ending. So what we have, these vesicles are full of neurotransmitter. Here is acetylcholine. In the nerve impulse, when the nerve impulse comes, the acetylcholine is released, and the acetylcholine actually attached to certain receptors in the muscle, it's called cholinergic nicotinic receptors, and initiate the changes that eventually lead to the muscle contraction. I just want to mention, and this is this point of the neuromuscular connection or junction. This is where the botulinum toxin basically work as treatment for spasticity, where it actually prevents the release of acetylcholine here. Okay, now if we look at the structure of the muscle, so let's say this is just drawing, I mean, mostly get from Ganong Physiology book. Basically, this is the muscle. If we take this is the muscle fiber, but then if we look a bit closely, we get what we call it the myofibril. Okay, we'll make it slightly bigger. So the myofibril is actually still made of filaments of certain proteins, and so these proteins are arranged in certain position, then they actually can interact or slide on each other and basically eventually cause the contraction and relaxation. Okay, how do they look? And again, another lovely picture of the electron microscope. And actually, as you see in the electron microscope, we have lines and bands, and this actually represent the different proteins and basically what we call it the sarcomere. Sarcomere is a unit of the muscle contraction function. If we look at it a little bit closer, let's just have this red rectangle. We can make it bigger just to make it really clearer. So this is the few types of protein that eventually lead to contraction. In the middle here, we call it the thick filament, which you may have seen. And then the thin filament is actually made of kind of three different proteins, the troponin, actin, and the tropomyosin. And certain, what we call chemical reaction or like kind of physiological reaction will lead to these two filaments of protein slide on each other and kind of make bridges. And actually, as they slide, they make the muscle, the unit of the muscle, the sarcomere, shorter, and eventually make the whole muscle shorter, which in action, in physiological action, that is muscle contraction, and then this is will cause movement or support position in the body. Here is again another picture, just see all the filaments together. So if you look, kind of this is this blue line and the other blue line is called the Z line or the Z disc, whatever you call it. And actually the distance between these Z lines get closer or shorter during the contraction, as you can see here. So the myosin in the middle, the green, and basically the combination of the actin and troponin in the thin one, and then they basically slide to each other and then cause contraction. And yeah, I thought actually I'd show you this lovely picture. This is each unit here is actually represent different protein or different basically ion. Here is calcium ions basically go inside and trigger the reaction of the sliding together these proteins. In the middle, then there is a molecule of ATP or adenosine triphosphate. This is basically the currency for the energy that actually being consumed during the muscle contraction. And here is another animation, just to the last one, tell you just how this imagination of the myofibril, how it does contract by the sliding of these two proteins or two groups of proteins in each other. So this is, we talked about the nerve conduction with the muscle structure and the muscle contraction. Then what actually produce the muscle tone? Now, the main basically function or source of the muscle tone is the stretch reflex. The stretch reflex is one of the simplest reflexes in the body, or is it? Is maybe the reflex arc is not as complex. However, controlling this reflex is quite complex and sometimes difficult to understand. But to make it simple, so each reflex arc starts with a receptor, and here is the muscle spindle. The muscle spindle is a modified muscle fiber, but it acts as a sensory organ for stretch. So it does have a little bit of muscle tissue in it, but it has a big bag full of nuclei, and it is sensitive to stretch. So from the muscle spindle, then we have a sensory nerve fiber, afferent, going through the dorsal root of the spinal cord. And then the center of the reflex is the spinal cord itself, where this nerve, afferent nerve, eventually relay to the another nerve cell, which is the anterior whole cell, basically, the lower motor neuron, and this is eventually send the motor nerve fiber to the muscle, where the muscle contract. I mean, we all know the knee jerk. When you hit the knee tendon, the leg jump or the knee extend, and this is basically the simple way of demonstrating the stretch reflex. However, let's just look at it again in picture. So this is the muscle spindle, as we said, is a modified muscle fiber, but basically act as a sensory organ. Send afferent nerve through the dorsal root. This is the dorsal root ganglia to the dorsal cone of the spinal cord, relay with the neuron actually going to the muscle. However, it's not simple in here. It actually also relay with another neuron that actually cause negative effect or relaxation effect to the antagonist muscle. So basically, when you have a reflex, when you have an increased tone or response of the muscle, you want the antagonistic muscle to relax so they don't have this co-contraction. This is in the normal, basically, physiology. Slightly looking in depth of the reflex, again, just make it slightly detailed, but all these bits are important to understand the regulation of muscle tone and spasticity. So again, I'm just saying it again, this is the this muscle spindle going to the spinal cord, stimulating the afferent nerve to contract. However, the actual affected neuron here send to itself through another interneuron, we call it, to regulate that reflex, so it doesn't go out of control. So it causes a feedback negative to say to the reflex, come down a bit. At the same time, there is another reflex, if you like, and this what comes from the tendon of the muscle rather than the muscle belly, which is called the Golgi tendon organ. This is another sensor that senses the stretch, and if the stretch is becoming a bit too much, then it basically goes to the spinal cord again and cause negative effect on the anterior horn cell. The other cells and other neurons are basically around to relay the descending control from the brain and the brain stem and basically the cerebellum to the spinal cord and other basically lower motor neuron to say, okay, well, hang on, we need to regulate this muscle tone a little bit further. So it isn't as simple as we think. So there is local control from the muscle, there is local control within the spinal cord itself, and there is a major control produced by the descending tracts from the brain stem and cerebellum. Here is just examples of the descending tracts. Most of the effect is inhibitory, although there is some excitatory effect. The main inhibitory, basically descending tracts, are the corticospinal, which is basically the pyramidal. But there is the reticulospinal. It depends where is it coming from. So the medullary, the one actually come from medulla, is inhibitory, whereas the one come from the pons is excitatory. Again, rubrospinal, basically another descending tract, which is quite interesting. It is inhibitory to the extensor motor neurons and excitatory to the flexor motor neuron. And again, the very famous one, the vestibulospinal, which is excitatory all the time, and they say that actually mainly excitatory to the anti-gravity muscles, that the muscles actually work against the gravity, basically, and this is quite position that we see in people with a stroke, where the vestibulospinal is still active. So these all tracts, it talks to, or the cells talk to each other through neurotransmitters, and again, I'm not going to go through all of them, but these are kind of the most famous one, and actually, to be honest, the most main one is the GABA or gamma aminobutyric acid, and this is the main inhibitory neurotransmitter. Through the GABA system, lots of medications we use that actually act to change the muscle tone or treat spasticity or increase muscle tone. The most known one is the baclofen. Glycine, which is another amino acid, which actually kind of enhance the GABA system. The glutamate and the catecholamines neurotransmitters are mostly excitatory. Some medication works through the catecholamines receptors. Tizanidine does that. So why do we have muscle tone? Normal muscle tone we're talking about. It's simple. If we don't have muscle tone, we cannot actually maintain position. We'll be like jelly. We fall down. People, when they have operations, if they give him muscle relaxant, they will be just relaxed, very floppy in the table, so the surgeon can operate. It does regulate movement. Just imagine if we don't have any muscle tone and we move, our movement will be absolutely jerky and jumpy, as there is no other basically resistance in the movement. And basically the muscle contraction always produce heat, and this to maintain our body heat too. So we'll start in pathology, and as I said, I'm trying my best to keep it as simple. So the main pathology here is basically upper motor neuron lesion syndrome. And in the upper motor neuron, where either the upper motor neuron itself get lost, dies, for instance, like a stroke, the cortical stroke, or the connection between the upper motor neuron and the lower motor neuron get interrupted, for instance, like this in spinal cord injuries. So at the end, what we have is what we call it negative symptoms. So loss of dexterity, weakness, as we imagine, but then lots of selective movement. Even you can find that the patient move a whole limb or a big joint, but not basically small joints. Well, this is what they call it positive symptoms. They're not actually very positive, but basically this is addition kind of signs and symptoms. And the main thing, basically, the complex of spasticity is not just like increased tone, but there is other things. So increased tone, as we all know, that exaggerated tendon reflexes, and clonus, basically, which is repetitive reflex, spasms, either extensor or flexor, and the co-contraction. This is very important, basically where the agonist and the antagonist muscle around the joint both will contract and have a rigid joint. Dystonia, which is kind of variable increased the muscle tone. This still can be produced by the upper neuron. And associated reaction, which I'm sure you all know about it, reaction which is involuntary, that triggered with other movement. For instance, like somebody yawning, then you find their arm moving. And as we all know, the release of other reflexes like Babinski response, where you have the upgoing plantar reflex. So what happens in the muscle? And again, try to keep it simple. So as you say, stiffness, we call it system-wide spasticity. Few things actually contribute to that. Contraction, changes in the muscle, then fibrosis, and late the muscle will be atrophic. So this is where we start the neurological changes, the neurological syndrome, what they call it abnormal intraspinal processing. So as we said earlier, there's disruption of a descending input. Basically, either these partially or totally the effect of the descending tracts get lost, and basically the stretch reflex get out of control. And if it is partially get affected, then the distribution of increased tone can be variable from patient to patient. And actually, the other thing, the interneuron reflex circuit, as we explained earlier, this is as well becoming, because they are under control from the descending, and basically they don't work as they should be. They don't produce that inhibition as it should be. One of the other things, which I'm going to repeat again, is this muscle spindle itself, because muscle spindle itself is a muscle fiber or modified muscle fiber, becomes more sensitive to stretch. Now, what is the clinical relevance of that? One is because the whole reflex becomes sensitive, and basically some stimulation, which sometimes isn't stretch stimulation, can still affect the muscle tone. For instance, we all know that pain in the limb, or constipation, or urine retention, this can actually trigger the tone in the affected limb. Sometimes effect on one limb, you can see it actually affecting the other limb, and the people say, well, basically the reflex becoming so sensitive that actually could travel to the other side or travel up and down. The other clinical relevance in here is these things can be treated in a way, as I said earlier, is like for instance the baclofen, and as we said again earlier, the ptylocoxin can actually interfere or the modulation or the effect of the reflex. And more or less all the kind of surgical procedure that interfere with the reflex, if we can basically interrupt the reflex, then we can end up reducing the muscle tone. So this is the neurological bit of the tone. However, there are other changes, and what we call it intrinsic hypertonia, or the beginning of contraction. So these changes actually happen in the muscle itself, rather than actually by the effect of the nervous system. So if you remember, we mentioned this sarcomere, which is the unit for muscle contraction. So if you have a myofibril, and which is basically a row of the sarcomeres, the number of the sarcomeres become less. So the myofibril becomes shorter. And then, as I mentioned, they basically this contractile protein. Then you have less contractile protein and more fibrous connective tissue in the muscle. But then these changes as well lead to the muscle spindle to be under stretch a little bit more. So basically, this is not entirely neurological, but if the muscle spindle, the tension of the muscle increase, or the pressure in the muscle increase, then the muscle spindle itself becomes sensitive. Again, clinical relevance. I mean, at this stage, I mean, still basically treating the neurological maybe will affect this one, but then the physiotherapy, the stretches, the splinting, the casting, all these things could help in basically maintaining the length of the muscle. And we have to be careful that these things can actually progress quite quicker than we expect. Just to show you, like this is how does the muscle look in the cross section under the microscope. As you can see, pretty beautiful cross section of the muscle fibers, very well arranged, very good color with the nuclei. So this is a normal muscle. However, then when we start, then it will be still you have some muscle fibers, but then the connective tissue and the fibrous tissue, they start to infiltrate the muscle. And later on, basically, as you could see, this is where the muscle will be mostly connective tissue. So as I said, basically gradual replacement muscle tissue with fibrous tissue and progressive muscle atrophy. At the end, some muscles would be looking like just a tendon, and we see that, well, hopefully not very frequently, but we see it when we try to do the background toxin injection under ultrasound guidance. So you see the muscle, echo of the muscle is actually quite strong because it loses the muscle tissue and loses actually water. But then the muscle itself becomes thinner and thinner, and sometimes, as I said, it will look like just a tendon. The clinical relevance here at this stage is very difficult to undo that without surgical intervention, basically to cut the tendon or elongate the tendon or transfer the tendon, etc., etc. And this is where actually only surgical treatment will be effective here. Thank you very much for listening, and we'll back to the whoever helping us here, and we'll be happy to hear your questions. Thank you.
Massive thanks, Dr. Morcos, for today. That was fantastic from us all, obviously, at the network, our attendees, and our Greater Manchester teams that this content's really relevant for. Thank you very much, Morcos. And obviously, we've been passed a few questions by some of the viewers today. So I'll kick us off with the first one that relates to outcome measures. So the question is, what outcome measures would you recommend to monitor tone and inform treatment options?
Okay, thank you very much. I mean, there are many ways, basically, and basically measures to measure the spasticity. I'm sure that most of the people know them. Basically, you could measure the range of movement of a joint. You could use whatever the known scales like Ashworth modified Ashworth scale or Tardieu scale. or frequency of spasm scale. These are all known. However, to be honest, on the clinical setting, when we treat spasticity, we always start by the end in a way, or what are our goals. So I identify the goals. What is it you want to achieve by treating the spasticity? For instance, reduction of pain, helping like care, or actual function. So basically, in my own practice, I set goals along with my colleagues, and the main outcome will be actually achieving these goals and involving the patients and the carer in basically measuring the achieving the goals. If you go really specific, will be like the goal attainment or the goal attainment scale. To be honest, we do not do the goal attainment scale, but we stick really to the goal attainment actually, or achieving the goals. And I think that's encourage everybody to use that rather than the other skills.
Okay, thank you very much for that answer. Perfect answer, and it probably feeds into the next question, to be honest. If we make assumptions around time points, obviously, because the question has been prompted, doesn't make assumptions or tell us what the actual time points are, but it asks about what time points should we use firstly for assessment and then treatment. But I'm aware that you'd have to make some assumptions on when them time points are for that to answer that.
I will try to respond to this question according to what I understand from the question itself. So if we look at the time point, for instance, from the event of the patient, I guess will be as soon as possible. In a way, even before the happening of the spasticity happen, you work toward prevention. So you do your assessment as soon as possible. You do your management as soon as possible. But if we think, if the question actually related to other kind of intervention, for instance, botulinum toxin injection, there is, I don't think this is a secret, but the therapy, for instance, is the best outcome for botulinum toxin injections. You get it if the therapy starts before the injections and then continue after the injections. We do have some standards, and we say like the therapy should start at least within the first 2 weeks of the botulinum toxin injections. But the best outcomes would be if the therapy started before the injections and then continued after the injections. Certainly, any other intervention, for instance, surgical intervention, again, I would say the assessment and the treatment should start as soon as possible, especially as soon as possible, as soon as being tolerated as well by the patient. How often do you reassess? The whole process of the, for instance, if I go for pharmacological treatment in addition to the physical treatment, I mean, you assess periodically, but I think to be really sure that you are doing some difference in the outcome. So basically, very frequent assessment wouldn't be advisable. But I would say like after 6 weeks of your intervention, then you repeat your assessment again. I hope I actually answered that question. I will be absolutely happy to discuss if the people would like to discuss it further, or put their questions in the comment part of this video.
Perfect, thank you very much. Yeah, and a great prompt there. Obviously, the viewers today and viewers who are watching this on our YouTube channel can actually contact Lisa, our administration, if you ever want to prompt any more questions towards Morcos. So we've got 2 more questions to answer. Again, both clinical to a slight degree, which means you must have done your job with the pathophysiology in that you've told them everything they were unaware of and they've no questions about it. So that's fantastic. But the third one is, does Greater Manchester have an accessible spasticity proforma, and where can they find that?
Yeah, that is, we have proforma already shared with all our colleagues. However, we can share it Again, we could actually email it to all the audience. The proforma has been actually produced by the Spasticity group led by Harriet.
Yeah, and I think you'll find as well actually on the website. So if you redirect to the website, I think the pro forma will be on there as well for you all. So just moving to our final question, and I suppose it's quite an open question in asking that does treatment differ nationally, or do the majority follow national guidelines?
Okay, I mean, basically guidelines, this is very, very important thing. Now, in the UK, as the UK is the country of the guidelines, so there are guidelines, there are national guidelines, but they're not actually, they don't cover everything. For instance, the NICE guidelines is mainly basically they cover mostly the children. There are some guidelines for kind of focal spasticity stroke. There are BSRM, British Society for Rehabilitation Medicine guidelines for using botulinum toxin. Recently, there is NICE guidelines for using cannabinoids in treating spasticity. The NICE guidelines for children, I mean, I think it's mostly can be applied for adults, but at the end, there isn't actually kind of one guidelines to cover all the management of spasticity. And I think this is because it is a vast bit, and to have one guidelines to cover it all, that will just produce a book which is available around. In Manchester, again, our spasticity group produced a pathway that actually, and actually, to be honest, that's shared between the neurorehab and the stroke as well. So the pathway is available. I hope it is in the website. Again, we could share it as well. Now, does the practice differ? Now, I will talk about my knowledge because yes, I do have colleagues around the country and outside the country as well. Generally speaking, the physical treatment is very, very similar. However, the treatment differs depending on the available resources and the available training. I give you an example. For instance, in Manchester, we have we have no problem getting botulinum toxin, so you use botulinum toxin quite frequently. Some areas they don't have botulinum toxin as we do, and they basically try to get other line of medical management, for instance, like the medication, the systemic medication, or nerve block, splinting or casting. And again, this is not available in every area, so sometimes they're really helpful, but some areas use it more than others because of the availability and the training. So to answer that, yes, unfortunately, there are differences between the different part of the country and the world. We do have guidelines to cover the children. We do not have general spasticity guidelines to cover all the aspects of spasticity in the country, as far as I'm aware.
Thank you very much. Really thorough answer, as always. I think from the point of view of the viewers and the network, I just want to say thank you again for taking time out to help present this pathophysiology webinar today. I think it's really interesting to see that the questions that were prompted were more around assessment and treatment rather than the pathophysiology. But I think it's really great to give the viewer the insight into the understanding of pathophysiology as well, in their clinical practice, whether they be a clinician or a therapist. So thank you very much, Morcos. Thank you to you all as viewers for prompting them questions. As regards certificates of attendance, these are not routinely sent out, but please feel free to contact Lisa, and Lisa will be able to get a certificate of attendance over to you via email. So on that note, thanks once again, take care, and we'll see you all soon. Thank you very much. Bye-bye.